Okay, good morning, everyone, or hello, everyone. It's night somewhere. I'm Dr. Lina Gonzalez, and I am a pediatric geneticist at UPMC Children's Hospital in Pittsburgh, Pennsylvania. I'm also a TANGO2 Research Foundation Research Committee member and clinician scientist. It's my pleasure to introduce our next presenter, Dr. Sergio or Checo Espinosa Alvarez. Sergio is a medical graduate and research coordinator for the TANGO2 Natural History Study. With a background in pediatric cardiology, Sergio focuses on patient outcomes and improving quality of life for those affected by a heart condition. Sergio, it's all yours.
Hello, everyone. I hope you all are having a great start to your day or maybe end to your day. Thank you very much for that introduction. And as well as they just said, I'm just very happy to be here. I just recently started working, so it's great to finally meet all of you here. And well, I've been given the pleasure to talk to you for a few minutes, and I want to take this opportunity to share with you a few updates on the natural history study. Okay, so first of all, one of the things that I want to talk to you about is what is the natural history study all about? We all know what this is. We all have an idea of what this is, but really, in short, at the end of the day, this is all about the patient that's been diagnosed with TANGO2. It is all about you, mom, you, dad, that have a kid that was diagnosed with TANGO2. It is all about basically any person that is involved with the care of a patient diagnosed with this disease. The aim of this study is basically to gather as much information as we can about these people. First, to be part of this study, we need to have some kind of genetic confirmation that the patient has the mutation. And after that, we need to start getting their medical information, their medical records. And even beyond that, most importantly, I would say, is that there is a story behind every patient, and we want to hear that story. We want to hear that from you, mom, from you, dad, from you, caretaker of your loved one. We want to hear everything about that. And for us to be able to do that, we have these very important instruments that we are going to be using. These are the first interview, and then on top of that, we're going to be building with the follow-up questionnaire. These are our most important tools to get to know these patients. So what are these interviews? So the first interview, it is basically the first time in which we are going to meet face to face, and we usually do this over a video call. This is your time, mom. This is your time, dad, for you to tell us everything about your kid, everything about your loved one with TANGO2. This is your time. You are going to tell us your story from start to the present day. We're going to give you that time. We want to hear it from you. And this is great for you as well, because in this first interview, you're gonna be with people who are studying this disease firsthand, and you also are gonna be with the experts in the field. You're gonna be with people like Dr. Miyaki. She's gonna be with you. She's gonna be giving you a lot of advice. She's gonna be giving you she's going to be asking you a lot of questions. We all are going to be asking you a lot of questions, but also we really want you to ask us a lot of questions as well. We are going to be learning from you, and you are going to be learning from us. And to build on top of that, we have the follow-up questionnaires. These are forms that we do after we have the first interview, because we're not just going to leave with that first interview. We want to have a clear picture of how the patient was when we first met him, and then we're gonna build on that. We want to see how the patient is progressing, and these are very, very important because as we are learning from other patients that we are enrolling and other patients that we are having these follow-ups with, we can share all of those new insights with you, and you can share all of the new things that you have seen with your loved one. You can share that with us, and if we do that, you are helping these other people that are enrolled, and they are helping you as well. So this is your time to tell your story, because we want to hear it, and we are going to hear it, and we are going to take note of everything that you say, and we're going to turn it somehow into something valuable for you. Why are we doing this? Well, we want to build a comprehensive clinical profile for each of the people that we have enrolled. We want to see what their similarities are, and we also we want to compare them. We want to analyze them, because we want to see and better understand TANGO2, so that we can give them a better treatment, so that we can give them a better care. And this is for both current patients and for future patients or people that are gonna be enrolled. That's what we want to do. And we want to avoid any major complications, and we want to help your kid, your loved one, to have a life that is as normal as possible. Okay, so now we're gonna get into the data, and here's what we're gonna be talking about. So we're gonna take a group of people that we have a follow-up of, and we're gonna see what they're looking like at this follow-up, and then we're gonna go back and see what they were looking during their first interview, and we're gonna be comparing these patients in these different times. So it's gonna be interesting to see what has changed, right? So who are these patients? Well, on average, they are 12 years old. They have an age range of 2.5 years to 31 years of age. 1/3 of these patients are adults, and the remaining 2/3 of these patients are younger than 18 years of age. So they're in the pediatric group. And they're very split in when it comes to gender. 48% of them are women and 52% of them are men. And they're from different countries, from all around the world. Half of them, well, 52% of them are from here, from the United States, and the remaining 48% of them are from countries outside of the United States, such as Italy, Saudi Arabia, Argentina, Brazil, India. So we have patients from a lot of different parts of the world. So now that we have a more clear picture of who these patients are, now let's see how their story started. So for that, we're going to talk about symptom onset and diagnosis. We want to look at, on average, how old were they when they were first diagnosed. So for this very specific group of patients that we're talking about, they were diagnosed, they were genetically diagnosed when they were 5.8 years of age on average, right? And when they are diagnosed, we try to recruit them, we start hearing their stories, and mom and dad or their caretakers start telling us all about these people. And they're telling us that they started seeing that something was going on with the health of their kid at around 1.4 years of age. So maybe they were delayed in some of their milestones. Maybe they were having any other specific symptom. Maybe they were having hospitalizations, but they did notice something was going on at this age. So as we can see here, there's this gap from the first onset of the symptoms, and then we have this other part where the diagnosis is made. So we have this gap. A lot of things can be happening in this gap. Okay, we can be having a lot of hospitalizations. We can be having a lot of visits to the doctor's office. We can be having a lot of diagnoses being thrown around, or maybe nothing really major is happening until something happens. And this is why it is really important to be able to identify and have suspicion for TANGO2 so that we can avoid complications, right? And what kind of complications are we trying to avoid? It is metabolic and cardiac crisis. And for this group of people, when we look at them at the time of the first interview, half of them, 51% of them, had already had a metabolic crisis, okay? Meaning that they had a worsening of their baseline symptoms, and also some of their laboratory values in their blood started going up. Values like CK, values like liver enzymes, maybe their blood sugar started to drop, and maybe they started having some changes in their electrocardiogram, and they need to be hospitalized. Why? Because we want to avoid something else that can happen on top of an acute metabolic crisis. The thing that we want to avoid is a cardiac crisis. And cardiac crisis happen on top of an acute metabolic crisis. As I said, they can have cardiomyopathy. They can have worsening of their arrhythmias. They can have other very dangerous cardiac manifestations that we definitely want to avoid. For this very specific group of patients that we had followed up, 21% of them had already had a cardiac crisis by the time of the first interview. Okay, so thanks to the efforts of all of the TANGO2 community researchers, families, the foundation, a link has been able to be found between vitamin supplementation and the prevention of these complications, and even the treatment of these complications. So that is what I wanted to show you here in this right side, because if we see that for patients that never had a cardiac crisis, the average age in which they started their vitamin supplementation was 5.9 years old. Okay, so when we compare that for patients that had a cardiac crisis, we can see that they were a little bit older when they started their vitamin supplementation on average. So here we can see another relationship pointing towards the use of the vitamins. And it's more interesting when we see that for this group of patients, the average age in which they had their first cardiac crisis was 7 years of age. So this is just reinforcing the role of the vitamins in the, and as we can expect, patients that are having cardiac crisis are on average having more hospitalizations. And when we add vitamin use or supplementation to the mix, we can see that for patients that by the time of the first interview, if they had started multivitamins or vitamin supplementation, they on average were having less hospitalizations than those who never started vitamin supplementation. So this is just reinforcing what we were saying. And we don't only have cardiac crisis and metabolic crisis, as we know. There are some baseline symptoms. There's something that can be there even before you start having a metabolic crisis or any type of crisis, which is what most of the time parents were noticing as the first sign of that something was going on with the health of their kids. So this is developmental milestones. A lot of patients were reported to be delayed in some kind of milestones. Here we can see that most commonly there were delays in crawling, in walking independently, and also in sitting, in rolling over, so on and so forth. This can be, these patients can be delayed in these areas because even if they haven't had any type of crisis. But what I wanted to get at is that when you add crisis, any type of crisis into the mix, it really affects their development, their skills, and that's why we really want to avoid them. So when we add metabolic crisis into the mix, here's what is happening. We can see that for patients that never had a metabolic crisis before they were walking, they walked at an age of 15 months. Meanwhile, for patients that had a metabolic crisis before they started walking, they ended up walking at a later age, at 28 months of age. And this is happening not only with motor skills like walking, this is also happening with speech, this is also happening with cognition. So we really, really, really want to avoid these these complications, because it is obviously putting the patient's health at risk in the acute moment, but also in the after they recover, they still can have some sequelae. So that's what we want to avoid. And that is one of the reasons that these patients are seeing a lot of physicians some of the times. So that's what that graph is. Here is basically a list of how popular some specialists are with these patients, and specifically with this group. Here we are seeing how many were seen by this specialist in the previous year, in the previous 12 months. So it is interesting to look at this, because just by looking at the specialist, we can kind of put together what the manifestations or their clinical picture is. We can see that they are, the more common ones are neurology, cardiology, and the primary care physician. This can be a pediatrician, this can be an internal medicine doctor as well. So all of these specialists are making new diagnoses, and we're trying to keep track of every new diagnosis that parents are telling us. So for these patients specifically, we are seeing these new diagnoses. In the neurologic and neurodevelopmental, we have a new diagnosis for these patients, okay? Something that we that I want to make clear is that specifically in this category, we have more than 4 diagnoses in the same patient. So this is just new diagnosis count. And here in this category, for example, we have global developmental delay, we have new onset of seizures. In musculoskeletal, we have hip dysplasia, we have scoliosis, and very interesting for me to hear also that mental health is being checked. We had a diagnosis of anxiety disorder, and also endocrine. We had, as we know, many patients have issues with their thyroid, so we are also seeing that. So talking a little bit more specifically about some aspects of these patients, if we take these patients that we have followed up and we look at how they were doing during the time that we met them during the first interview, we can see that 66% of them reported spells at that time. And by the time of the follow-up, let's just round that up to 30% are continuing to having spells within those last 12 months. So that means that in the previous 12 months, at least 70% of these patients were not having spells. And for those that were having spells, these are the most commonly seen symptoms, the most commonly reported symptoms. Most popular, as we can see, is fatigue and lethargy, speech changes. We can see mood and behavioral changes. We can see gait disturbances and drooling and salivation. Those are the most commonly seen ones. And we can also see about the duration of the spells on average. We can see a median duration of 30 minutes for the spells for the patients that were having spells during this follow-up. And something that is very, very interesting is also that when we look at patients that were having spells in this previous year, we actually can go back and look at what vitamins were they on, right? Were they taking the right B vitamins? So I did that, and we did that all. And turns out that they were reporting to be taking the appropriate vitamins. They were reported to be taking the appropriate amount of vitamins. But then they also, more than half of them, also reported to be missing some doses, around 4 to 8 doses a month. And that's just what they are reporting. That's why it is, I think, the follow-ups are very, very important, because that is the great time for us to be reminding people about the importance of certain stuff. For instance, the importance of taking vitamins regularly. Also, when we talk about neurology, by the time of the first interview, when we take this group of people and we look at them, when we first met them, 39% were having seizures. Now they're being treated. All of those patients are on anti-seizure medication, and now 27% of are continuing to have seizures at the time of a follow-up. Here in this statistic, I'm including that new onset of seizure that was diagnosed. We can see something similar with hearing. Now, by the time of the follow-up, we have now in this group of patients two new, one new, two in total cases of decreased hearing or abnormal hearing. Again, something similar with optic nerve. By the time of the follow-up, we have now 5 patients that have reported to have had specifically optic nerve testing, and with an abnormal result being optic atrophy. And now we know that patients have some degree of stiffness at baseline, most patients really. But by the time of the first interview, only a really small percentage really reported any true concern about that. And by the time of the follow-up, more people were expressing concern about stiffness. And so much that 50% of these patients are actively receiving a type of treatment. This can be pharmacological, or this can be injections. Something else that we have found, which is, again, I want to say very important for us to be talking to patients, to be getting all of those insights, is that we had that one case in which one family just mentioned that their kid was having higher than average pain tolerance. So when we had that, when we had that information, what we did was we started asking all of our other patients if they were having higher than average pain tolerance, and we are now finding out that several patients are having that as well. So far, in this group of patients, we can see that at least 35% of them are having higher than average pain tolerance. And now on to the section on endocrinology. 39% of patients, by the time of the first interview, they are having a thyroid abnormality. And by the time of the follow-up, one more patient was added to this list. Most of these patients were having hypothyroidism, but there were some cases in which there were some reports of thyroid nodules, just a couple of cases, and then one isolated case of papillary thyroid carcinoma. And what the most of these patients are having hypothyroidism and needing to be on replacement therapy. So now, where are we now? So in summary, We have one more patient with hearing loss, which is 2 in total for this group of patients that we have followed up. We have 4 new patients with an abnormality in the optic nerve, which is 5 in total for this group. We have one more thyroid abnormality, which is hypothyroidism. Now we have around 40% of this group. We have a decrease in spells being reported. Now, 30% of patients are being reported to be having spells. We have a decrease in seizures, a decrease in seizure reports in the last 12 months. And all of these patients are on anti-seizure medication. We have now more patients are reporting concern with stiffness, and half of them are on stiffness medication, some type of treatment. And now we have 35% of patients that we have found out that have higher than average pain tolerance. So all of these changes, all of these new things being found, all of these changes in the frequencies is just because these patients are being seen by a multidisciplinary team. They're being treated for their thyroid, they're being treated for their seizures, they're being treated for their stiffness, and also I can tell you that 100% of these patients in this group are on B vitamins. So that is also another factor that is definitely helping. There have not been in this group another instance of cardiac crisis or metabolic crisis since the first interview for this specific group of patients. So another thing that I also wanted to talk to you about is a study that is being done. It is still in development. It is an anesthesia outcome study that it is being done by Dr. Miyake, by Dr. Kanya, by Dr. Howe. And I just wanted to show you the preliminary results that we are getting. This study is mainly done to analyze the perioperative outcomes of TANGO2 patients going under procedures requiring anesthesia. So we are analyzing a lot of laboratory markers. We're analyzing the EKG. We're analyzing the CK in the blood. We're analyzing the liver enzymes in the blood. We're analyzing troponin. And all of this, we're doing it in a 48-hour time window, 48 hours before, 48 hours after, because we want to see if there's a direct relationship between certain type of anesthesia and the development of any kind of crisis. The goal is to identify clinical risk factors and improve procedural safety. So for this study, we have so far 10 TANGO2 patients, totaling 36 procedures. We have an age range of 1.5 years to 24.5 years. 1/3 of these procedures were outpatient procedures, meaning that they did not have to be admitted to the hospital. And for the inpatient procedures, there were patients that were already admitted to the hospital or patients that had to be admitted because of the procedures. So just to wrap this up really quickly, I just wanted to let you know that within this 48-hour time window, we did not see any complications. We did not see any crisis. But there is something that I do want to mention. Just outside of this time window, and we're gonna get into that when we can. We had a patient that did have a crisis, and this was the patient that had the longest procedure. It was an orthopedic procedure. And also, there was another patient that had 2 procedures done while he was under while he was on a metabolic crisis as well. Those are the things that I just wanted to make clear, that these are just preliminary results, and we're gonna look into that. So I think I'm gonna wrap this up right now because I'm running out of time, but I'll be glad to give updates later on this study.
Well, thank you, Sergio. This has been it's very illuminating, and it's important to see like all the advancements we've gotten from the natural history study and the importance of having those follow-up interviews. So I really encourage all of our participants to circle back and like follow up with the TANGO2 Research Foundation and the natural history study, and making sure that we're staying up to date in either as first interviews or as our follow-up interviews. We'll have a little bit of time to answer a couple of questions before our next speaker. And if you have a chance, Sergio, if you could type in some of the answers for the ones we don't necessarily get to. There's 2 different questions from our panelists and from the audience that kind of discuss about B vitamins and what you are using as your concentration that you consider appropriate or adequate to define the category of having adequate B vitamins.
We were looking at specifically, we were looking at B5 and B9 vitamins, and for B9 for folate, we were looking at 400 micrograms and daily, and for B5 pantothenic acid, we were looking at least 5 milligrams of pantothenic acid. Really around 5 to 20